Hi, everyone, and thank you for tuning in to this talk. In this presentation, we introduce you to the term borderpolar, which is psychiatric lingo for people who simultaneously meet criteria for two disorders, borderline personality disorder and bipolar disorder. We discuss how psychiatry differentiates between the two while simultaneously diagnosing them based on very similar symptoms. Then we discuss why this is a concern for the sociology of mental health. We also present two types of empirical data. First, we share results from our analysis of psychiatric epidemiological data that describe differences between people who meet diagnostic criteria for borderline, bipolar, or both. And second, in keeping with the free to be me theme of this session, we preview original data we recently collected from people diagnosed as borderline, bipolar, or both to see what they think of their diagnoses. I first heard the term borderpolar 3 years ago when I asked a psychiatrist to explain the difference between bipolar and borderline. She said they overlapped and that some people have both, referring to them as the borderpolars. She went on to say that she only works with people who have bipolar disorder because people with borderline are just too difficult for her to deal with. I soon found she's not the only person using the term. There's a Twitter account entitled Borderpolar Central and a blog and a publication in Psychiatric Times with borderpolar in the title. There's also a great deal of conversation about borderpolar on Reddit, an open source discussion forum where people diagnosed with both conditions ask each other for feedback, such as in this post from earlier this year by someone who goes by the handle borderline ready to cry. There's also a scholarly literature on the comorbidity between borderline and bipolar. Most studies find that about 1 in 5 people with bipolar or borderline also meet criteria for the other disorder. And most psychiatrists believe they are distinct conditions, although a few argue that borderline should become a subtype of bipolar. This slide draws attention to common symptoms between the two, including intense anger, affective instability, transient paranoia, impulsive behaviors, unstable relationships, and suicidality. Highlighted in red are the main differences. Fear of abandonment is typical for borderline, whereas attachment issues are less common with bipolar. Symptoms like mood instability are more fleeting with borderline and more long-lasting with bipolar, based on the belief that borderline mood instability is provoked by environmental triggers like relationship conflict, whereas bipolar mood instability is organic. Given how many symptoms of borderline and bipolar are virtually the same, it's surprising that psychiatry portrays them as completely different disorders. Borderline is classified as a personality disorder, and I do not know of anyone who would view that designation as a compliment. Whereas bipolar is described as a brain disorder, often likened to diabetes in the hopes that the analogy will reduce stigma and increase medication compliance. The purported causes of the two disorders are also different. Borderline is linked to exposure to childhood adversity and difficulty regulating emotions, whereas bipolar is believed to be largely genetic, although triggered by stress. Frontline treatments for each disorder are also different. Intensive specialized psychotherapy is recommended for borderline, whereas lifelong reliance on psychiatric drugs is recommended for bipolar. Finally, while borderline is portrayed as difficult to treat, experts say that it resolves completely over time in the majority of people if they receive appropriate treatment. Whereas bipolar is believed to be permanent, impossible to prevent, and impossible to cure. So why is the phenomenon of borderpolar relevant to the sociology of mental health? First, there are no biomarkers for borderline or bipolar. That's right, no DNA tests, no blood tests, no brain scans available to validate the presence of either disorder. Rather, diagnosis is based on self-reported symptoms and how well they cohere with socially constructed categorizations of psychiatric disorders. Second, clinicians have diagnostic biases. Psychiatrists tend to prefer a diagnosis of bipolar over borderline because their treatment of choice is not indicated for borderline, and their entire business model is based on prescribing medications. They also tend to express greater stigma toward people with borderline than bipolar, just like the psychiatrist I consulted on the matter. Third, the consequences of being labeled borderline, bipolar, or both are considerable. Diagnosis or misdiagnosis leads to treatment, and being prescribed potentially dangerous drugs when psychotherapy is what one needs, or vice versa, may preclude recovery and do lasting damage. Being labeled as borderline and/or bipolar may also lead people to internalize stigma, which is associated with lower self-esteem, social withdrawal, unemployment, income loss, lower life satisfaction, and a sense of futility regarding one's future potential. The NSARC-3 is a psychiatric epidemiology study that used an in-person standardized survey to estimate prevalence of psychiatric disorders and related phenomena in a sample of over 36,000 adults that represent the US household population in 2012 to 13. We estimate that 5.9% of the sample met criteria for borderline and 2.4% met criteria for bipolar. Of these, 388 people met criteria for both. Interestingly, almost half of the people with bipolar also had borderline, whereas fewer than 1 in 5 people with borderline also had bipolar. We created 4 mutually exclusive categories of people based on their diagnoses of borderline and bipolar, and used several measures to compare the relative weight of economic, psychological, and social disadvantages associated with meeting criteria for one, the other, or both versus neither diagnosis. This table highlights notable demographic differences between groups. Men were slightly more likely than women to be classified as bipolar, whereas women were more likely to be borderline. Blacks and Hispanics were evenly distributed across the 4 groups, but Asian Americans were much less likely to be bipolar, borderline, or both than neither. In contrast, Native Americans were more likely to be borderpolar, and whites were more likely to be borderline relative to neither diagnosis. The remaining demographic differences cohere to a pattern wherein the so-called borderpolars are the most disadvantaged, followed closely by people with borderline, and in a somewhat distant third place by people with bipolar, all in comparison to those with neither diagnosis, who are consistently the most advantaged. For example, borderpolars are least likely to have a college education, to be married, to have a household income of $80,000 or more, or to be employed, followed by people with borderline, then bipolar, and then those with neither disorder. However, borderpolars are most likely to be divorced or separated, to receive means-tested income, or to be disabled. Here are 7 adverse childhood events where the same pattern is apparent. The percent of people who experience each event in childhood increases as you read from left to right, such that people with neither disorder are least likely to experience each event, followed next by people with bipolar, then by those with borderline, and finally by those with both disorders, who are most likely to report each event in childhood. This table highlights differences in the average number of stressful life events people experienced over the past 12 months, from a list of 16, including things like moving, getting fired, or having a relationship end. Again, people with neither disorder reported the fewest stressful events over the past year, followed by people with bipolar, then borderline, and lastly, the borderpolars. The same pattern holds for exposure to traumatic life events in adulthood. Out of a total of 16 possible traumas, like being sexually assaulted, beaten up, kidnapped, or held hostage, people with both disorders reported the highest average number of traumas and were least likely to report no traumatic events whatsoever. We also examined several indicators and scales of emotional, social, and physical well-being. The rows highlighted in red indicate the same pattern you've been seeing. People with both disorders are most likely to have attempted suicide, for example, and they also report the highest average number of health conditions and the worst overall physical health, followed next by people with borderline, bipolar only, and neither disorder. So what do we make of these findings? First, they confirm that psychiatry is on the right track in linking exposure to childhood adversity to borderline, although people with bipolar experience their fair share of adversity too, and people with both disorders are in by far the worst situation. Second, our diagnostic estimates contradict the trend in psychiatry to diagnose bipolar when borderline is a better fit. They suggest that borderline is more prevalent than bipolar and hint that misdiagnosis of borderline as bipolar and all the harm that potentially entails may be a major public health problem. Public mental health care needs to increase availability of intensive psychotherapy for borderline, including early intervention for children exposed to traumas to try and prevent the development of mental health problems in adulthood. An interesting fact about the NSARC data is that while they diagnose people with serious psychiatric conditions, these people may never see the inside of a psychiatrist's office, and there's no way to know from the data set who has versus has not sought psychiatric treatment. To learn more about people who have actually been diagnosed with borderline, bipolar, or both, we designed a survey and collected data from 100 people diagnosed with borderline, 100 with bipolar, and 65 with both. The first question we asked was whether they agreed with their diagnosis. People with borderline only were more likely to agree than people with bipolar only. People diagnosed with both were more likely to disagree with the bipolar diagnosis than with borderline, but about equally likely to agree with both. We asked those who did agree why, presenting them with a list of 8 possible reasons. Most people tended to think that their diagnosis helped explain their behavior, thoughts, and feelings, and helped them understand themselves. Highlighted in red are responses that vary by diagnosis. People with bipolar were more likely to say it runs in their family and that medication helped control their symptoms. We also asked those who were not sure or who disagreed with their diagnosis why, with 9 possible reasons. As you can see, people with borderline were more likely to say, I am not convinced I have a personality disorder, than were people with bipolar to say, I'm not convinced I have a brain disorder. In the borderpolar group, people were more likely to disavow their similarity to other people with borderline than to other people with bipolar. Stay tuned, as I have a lot more survey data to share with you from these people, and I plan to conduct follow-up interviews with some of them. Thank you for your time, and here's how to reach us if you want to learn more information about our study.